Okay, welcome back, everyone. We are going to get started with the next session. Before we get started, realizing that Katrine is the first person to present, I also wanted to make sure that I especially thank our international presenters who are coming from many different time zones and really kind of moving things around in their schedule to accommodate the conference. So thank you very much for doing that. And with that, let's get started with Katrine.
So thank you very much. I will just share my screen first. Okay, thank you so much for inviting me to this conference. It's really a really good idea, I think, to get this different perspective for many different countries. And today I will give you some insights to some research I've been doing for early health programs in Norway. So I will not use much time on comparing to the US. We just saw some very interesting comparisons to Canada. And I think Norway, for example, life expectancy in Norway versus US is quite similar to the average I just saw in Canada. So we are typically 4 to 5 years higher than the US. In Norway, we have a range of universal health programs and healthcare, universal healthcare, and I think the main topic for me is to think perfect. Definitely, we also have our issues. Many of the issues that Canada just had is also an issue here. But I think some of especially the early health programs, there are some interesting insights that are important. So like you all know, it's really hard to separate effects of policies from the strong gradient in health. So people with poor or good health are, of course, very different from each other on a lot of observed and unobserved. So in the stuff that I will show you now, we will use different methods to identify, try to really kind of get at the causal effects of these early health programs. And the main tools we use, of course, are different randomized experiments and natural experiments. And in Norway, we have this very rich register data typically. That's so we have the potential to kind of use different natural experiments to try to answer some of these questions. And to my research, transparency and figures are key. So I'll mostly show you some figure that really gets to some of the main core results. So I'll kind of used most of my time on 2 studies. So the first one is one we have on infant healthcare and long-term outcome. So this is a study that looks at access to mother-child healthcare centers. So these centers, a lot of countries have these typical centers, and this is where you would typically go after you've been out of the hospital after you have a child, and it's where you go to get follow-up checks and advice, for example, for breastfeeding or other nutrition. It's also today typically centers where you get vaccines and so on. And this, when it was rolled out in Norway in the 30s and 40s, it was a very cheap intervention. So the cost per child in 1950, if you convert that to 2014, it's $22. And it's more expensive today for many reasons, but it's also because vaccines are a bigger part of the program and so on. So many countries have this universal type of mother-child healthcare centers, but it's actually not, for example, a universal policy in the US. So it's many children that does not have access to these centers in the US. There is an AER paper by Heidi Williams and co-author, for example, that show that there is at least 10% of children in the US that does not have access at all, and the access also vary a lot by rural and urban areas and so on. Well, in Norway today, 99% of children access these types of centers. So what we do in this paper is to go back in time to try to learn something about how does this center affect long-term outcomes. And what we use is that we have variation in whether children and families had access to this center by comparing children that within municipalities were born just before or just after the center opened. So it opened across time from, I think the first center opened in 1918 and the last center in our sample opened in 1960. So we have a long panel in that sense. And then we compare children across municipalities with and without centers. So it's kind of a difference in differences, where if you see the graph here, 0 will be the time that it opens. And if you're between 0 and 1, in that municipality, you were eligible for this center. And then we go back to the archives and get data on who went to these centers and so on. And we saw that, so before you had an opening, you didn't have a center to go to. And afterwards, we saw an increase to 40–50% almost immediately. And it was increasing also in the years after. And like I said, today it's 100%. But it took some time to get people to use them at this time period. So what do we find? So then we can go back in our register data and follow these people for almost their lifetime. We can even look at the longevity, but it's a little. They are still a little bit earlier still for that. But we look at, for example, years of education, and we looked at income in the prime year between age 30 and 50. And what we find is that if you were born in a municipality after the center opened, you have more education, about 0.15 years, and you have 2% higher income. And this is quite persistent, although a little bit bigger in the beginning, in the first years. You see it for many of the cohorts born just later, also after the opening of these centers. We also have some data on adult health. So we can, for example, create a health index based. So at age 40, you have to do a test in Norway that is a cross-country test and check all type of health issues, blood pressures and so on. And using a lot of these type of data, we can create a health index. And we show that if you had access to these data, you had better health also at age 40. And you were also higher, for example, taller, about one centimeter tall. And then, of course, the question is, why are these centers working? Always difficult with register data. But I think one kind of important finding that we had is that this also seemed to affect infant mortality rates, and especially lower infant mortality rates caused by diarrhea, which is really a sickness that is linked to nutrition. So it seemed to be really important that these centers provided information or help with nutritional advice. It could both be breastfeeding and formula, of course. So it seemed to be like that all this kind of low-level information channel and the fact that these children were followed up and checked it's an important reason probably why this has long-term consequences for these children. And just going back quickly to the US, these infant mortality rates are much higher in the US than in Europe. And Heidi Williamson, again, and the co-author speculated that could be because of the low access to this type of child well-being centers. But in the US, it's really hard to get data on that. So I think our paper was one of the papers that showed that indeed could be one explanation for why the infant mortality rates varies across Europe and the US, because almost all children have access to these type of centers. But this is without the data. So just to sum up that paper, early life health intervention can have long-lasting effects on both health and other outcomes. And we also show that it passes a very kind of crude cost-benefit analysis. Even with the 10 times higher cost in 2014, the benefits are much larger if we think about the lifetime earnings effects that we find. And this is not even taking account of the health, potentially extra health effects and so, which is hard to quantify in this setting. The second paper I wanted to briefly go through with you is the paper that I had with Prashant Bharadwaj and Chris Nielsen in AER in 2013, where we looked at another type of early life health intervention, which was like access to neonatal care, which differs if you're born below or above 1,500 grams. And I think this is an important question also in thinking about this health economics, is whether the resources spent on this really have an effect also later in life. And we could look at register data both in Chile and Norway. And we look both at, for example, infant mortality rates in the short run, but we also then have educational attainment in school, which was more the longer run. But in this case, the children are not old enough to follow them into the labor market, but we had different measures of grades in school. And the method then was to look at whether infants just below 1,500 grams or less than 32 weeks gestational age were more likely to get treatment than infants just above 1,500 grams. This has also been shown to be the case in, for example, the US and other countries, which haven't had data to look at the long-term effects, but they also find these discontinuities in care around 1,500 grams. And if you were below 32 weeks, you received treatment regardless of birth weight, but 32 weeks and above, this 1,500 gram cutoff kicks in. So you only expect effects for the children that are 32 weeks or older at time of birth. So what you see from the right, from Norway, we know if you go to this NICU, this neonatal care intensive, and you see that they do this more if they are just below 1,500 gram and above 32 weeks. Then we looked at infant mortality rates. So if you were just below 1,500 grams, infant mortality rates is only 2% compared to 4% for those just above 1,500 grams. And we find similar findings in Chile. I didn't put all the graphs, but the pictures are in the same kind of ballpark. The same goes for grades in junior high school. So if you were just below 1,500 grams, you see to the left in this figure that you have higher math. So this was math grade. It's not. It was for other types of test scores too. You had about 0.2 of a standard deviation higher test score than if you were just above 1,500 grams. So just a quick summary on this. Then the early life health intervention can have long-lasting effects, and we have done similar findings in Chile, and more recently this has been replicated in, for example, Denmark and some part of the US. And I think medical procedures geared towards low birth weight infants can reduce mortality and raise test score. And we also show in our paper that surfactant, which is a medicine that helps breathing and lung capacity, appears to have added benefits. So it seems to be kind of one of the so it's a package of treatment below 1,500 grams. So it's a little bit hard to get exactly at what is the mechanism for why these children do much better. But surfactant is definitely one of the key inputs that seem to matter. So policies geared towards low birth weight should weigh these long-term benefits also on education and potentially other outcomes we don't have yet. So I think just to kind of give some comparison. So in contrast to these examples of early health policies, just in Norway, the Norwegian government, for example, have used billions of dollars on programs to try to reduce dropout rates from high school. So we have quite high dropouts from high school in Norway, because high school is voluntary, and there's been many programs, and there's been a huge study now that show no measurable benefits of any of this use of these billions of dollars. This doesn't mean that there are not some example of education policies that work and health policies that does not work. But how I see the literature is that it's much more promise for early health policies than education policies to also reduce this long-term education and income, and maybe also longevity. You have to understand the context, and future research need to focus on why some of these policies work in some environments and not others. And implementation of this, the resources, the incentives, and the environment are key. So it's not clear that just taking these policies and then applying them in the US is easy. Like, it's a huge country, a lot of heterogeneity and so on. So implementation will be a big part of thinking about how you could use it. So just at the end, I just wanted to mention that that I'm part of this Center of Excellence that looks at many of these type of questions. And at the moment, we are focusing a little bit more on health during the school years, not only on the early environment. So you, for example, have one project where we look at school environment and mental health in high school. So using various data where we know the diagnosis and treatments of mental health, we are trying to use these data combined with lots of data on whether you are eligible to different selective high schools in Norway. And we find that if you go to a more selective high school, on the margin, you have this is positive, especially for girls' mental health. And it really looks like teachers are the key mechanisms. So by using a lot of variation in different inputs in different high schools, teachers seems to be key, and which is really, I think, important in the debate on how now when we see a huge increase in mental health issues for youths. We've also had a project where we looked at health-related role models outside the school environment. So we have used this random variation in exposure to female GPs. So we have a system where you have a general practitioner in Norway assigned to you, and if someone dies or quits their practice, you are just given a new doctor, and therefore you have this kind of random variation. And we see that for girls also, for some reason, this can be positive. For if you get a female GP, you're more likely to choose STEM subjects in school than if you get a male GP. So it seems that it doesn't have to be always school should focus on schools. It's kind of something. It's really, sometimes you need to think that schools and health are very, very interlinked. So thank you very much. This is just my little bit covered, because I have many different projects on this. So this is just how we could follow some of this. Thank you.
Fantastic. Thank you so much, Katrine. That is fascinating, and we've so much to learn on in the US on these topics. There's so much less ability to really get to the key evidence like this. So we're collecting questions, and we're going to ask questions to both Maya and Katrine together for 10 minutes at the end of this session. So I'm going to move straight to Maya right now, and then we'll go back to kind of the joint questions after Maya's presentation. So Maya, if you're ready, please go ahead.
Great, thanks so much. Let me go ahead and share my screen as well here. Okay, so thank you, first of all, very much for including me in this great conference. It's been really interesting so far, and I appreciate this opportunity to talk more about families and health, in particular, trying to learn some lessons from the Swedish parental leave system. A caveat is that I am not Swedish at all, nor am I Scandinavian at all. And in fact, everything that I know about Sweden mostly comes from my brilliant co-author, Petra Persson, who's here at Stanford and who has been, my co-author on all the work that I've done on Sweden. So the research that I'll be presenting here today is really on both of our behalves. As Katrine kind of highlighted in the discussion about Norway, while a lot of the healthcare policy often focuses on individual patients or hospital-related outcomes, doctors, or like aggregate health outcomes at various levels of geography, the the family, or what happens kind of in other settings, so schools and so forth, is also important, right? And this type of framing leaves out the role of the family in determining health and well-being, and in particular, how other types of public programs that may not be seen as sort of purely healthcare programs that also support families interact with that broader healthcare system. So there's lots of different things I could talk about, whether it's childcare policy or something else, but specifically, I'll talk more about the area where I have done quite a bit of research, which is paid family leave, and drawing the lessons learned from Sweden. So just to give you some general statistics on the US context, and then we'll switch to other contexts. So the vast majority of parents of young kids juggle work and family responsibility, right? So according to the most recent data, 71.5% of American mothers, 93.5% of American fathers with children are in the labor force. Of course, these issues have been highlighted extensively in light of the ongoing COVID-19 pandemic, with the challenges that many working parents and specifically working mothers face in juggling those responsibilities. When it comes to mothers of young children, so infants under age 1, the labor force participation is still 58%, so more than half of all American mothers do work. And so paid family leave is a highly relevant policy for this population because it provides workers with time off work, usually with partial wage replacement, to care for their newborn or adopted children, as well as for severely ill family members, although I'll be focusing today on the part of it that's for kids. And when you sort of talk to advocates surrounding paid family leave, a lot of times this policy is motivated as a tool for promoting career continuity for new parents, in particular new mothers, and reducing gender inequality, both in the labor market as well as at home, right? And that said, the evidence on these impacts, whether it's women's career continuity or sort of gender inequality type measures, is relatively mixed and depends a lot on the features of the program that I'm not going to get into here. But broadly speaking, I would say paid family leave is not a silver bullet for solving gender inequality. That said, the evidence on the health benefits of paid family leave is actually more consistent across many studies and contexts. And in particular, Katrine has an excellent paper looking at the introduction of paid maternity leave in Norway in the late 1970s and its impact on long-term outcomes of kids. So just to give you a general sense of the policy landscape in the US versus, Canada and Europe. So the United States is one of 2 countries in the world. I believe the other one is Zimbabwe, with no statutory paid maternity leave policy at the federal level. And it's the only OECD country without a paid parental leave program. So there is unpaid leave. So the Family Medical Leave Act, 1993, provides 12 weeks of unpaid job protected leave. It does have fairly stringent eligibility requirements. So recent estimates suggest about 60% of private sector workers are eligible. And then there's state level paid family leave policy that currently exists in 8 states. So it's either been implemented or passed and is going to be implemented in the next year or 2. And these policies provide somewhere between 4 and 12 weeks of partially paid leave. Now, the rest of the states and the rest of employees are subject only to the benefits that are being provided by their employers. And recent data suggests that only 14% of private sector workers have access to paid family leave from their employers. And this access is highly unequal. So for example, amongst workers in the bottom quartile of the wage distribution, the access is about 5%. By contrast, there's a lot of variation in policies across Europe as well as in Canada, but generally like the lowest amount is 2 months and all the way up to 3.5 years. And with 70 to 100% of wages being replaced, at least for part of the duration. So the US is a clear outlier in terms of the provision of paid family. The other thing that's going to be relevant to the research that I'll be speaking about shortly is that in addition to sort of having leave for mothers to take to be able to both recover from childbirth and also care for their newborn children, over the last few decades, there's been a growing movement around the world to encourage fathers to also take parental leave. And this has been mostly through policies that earmark a part of the leave period to fathers only. And these are colloquially referred to as daddy months or daddy quotas. These exist in a range of countries today. Again, these are not usually motivated from a health perspective. Usually these policies are motivated by a desire to promote father-child bonding and improve gender equity in the labor in both the labor market as well as in household. That said, again, the evidence on sort of these types of impacts is quite mixed. And we know even less about the potential health impacts of fathers being able to take leave, especially on the health of mothers. And that's what I'll be focusing on today, sort of taking this as an example of a way in which these types of policies could have really measurable impacts on health during a critical period in many women's lives. So just to give you a general sense of what we're talking about here. So health issues in the postpartum period are actually quite widespread. So there's various estimates of these things, but some surveys suggest that over 1/4 of women substantial pain in various parts of their bodies during the entire first postpartum year. More than 1 out of every 100 new mothers are readmitted to the hospital within the first month after childbirth. Mental health issues are also quite common. So about 1 in 9 women experience symptoms of postpartum depression. And then this issue has been receiving increased attention in the last few years. The US maternal mortality rate has actually been rising in the last few decades. It's currently at about 26 deaths per 100,000 live births. And the US is the only country in the world in which the maternal mortality rate has actually risen in the last 25 years. It's been falling everywhere else. When it comes to maternal health, again, policy discussions often focus on the role of the healthcare system. So what's happening in the hospital, around the time of childbirth that's causing these problems? And of course, that's a really important question. But the reality is that the vast majority of women, spend just a few days in the hospital after giving birth, and then the majority of their time in the postpartum period is actually spent at home. And we know less about the influence of the mother's postpartum environment at home. And this is, I think, really highlighted quite well in this quote by Dr. Neil Shah from the Harvard Medical School in an interview about America's rising maternal mortality rates. So he says, what's important to understand is that most maternal deaths happen after women have the baby, and the fundamental failure is not unsafe medical care, but a lack of adequate social support. A lot of the risks around childbirth happen after the baby is born, during that vulnerable time when you're trying to care for an infant while also taking care of your household and doing all the things we expect of you. So this is where this recent working paper that I have with Petra Persson comes in. So what we were interested in looking at is whether fathers being able to flexibly take paid family leave benefits in the postpartum period has an impact on maternal health. And what we do is we leverage variation from a reform in Sweden that happened in 2012 that essentially increased fathers' flexibility in being able to use paid leave benefits on a flexible intermittent basis during the first year post-childbirth. And then we study fathers' leave take-up as well as maternal postpartum physical and mental health using a regression discontinuity difference and differences design. The RD is due to the fact that eligibility for this reform is based on the child's exact date of birth. And the diff and diff part is due to the fact that we want to net out other seasonal differences. So a brief primer on the specifics of the parental leave system in Sweden. So Sweden has had gender neutral paid parental leave since 1974. The exact length of time has varied over time, but basically since early 2000s, it's been 16 months of job protected leave. 13 months of that leave is 78% of wages are replaced up to a ceiling. And then the last 3 months just have a flat rate benefit. And this leave is flexible in the sense that it can be taken in multiple spells. Sorry, I just got a notification that this is being recorded, but I think I knew that. Okay, and then leave. This leave is importantly assigned at the household level. Okay, so and you can think about this as just being assigned to each per child. Okay, so the two parents of each child get the 16 months of job protected leave, and historically they've been able to sort of share it in any way they wanted to. In practice, though, the vast majority of this leave was being taken by mothers. And so motivated again by these sort of gender equity concerns, Sweden has implemented what are called 3 daddy month reforms, that each of these earmarks 1 month of that leave to each parent, and critically, they cannot be transferred across parents. And the other thing is, again, to promote this sort of father-child bonding and fathers being able to sort of share household responsibilities and childcare duties and whatnot, fathers are supposed to use this leave on their own with the kids. So they cannot use this leave at the same time as mothers, okay? In particular, this restriction on simultaneous leave use is actually an important aspect of the Swedish parental leave system. And I think is gonna, thinking about this is gonna get to this broader issue, of that the design of a paid family leave policy matters critically for its impacts on health outcomes. So in Sweden, until 2012, until the reform that we study, fathers were essentially entitled to only 10 days of what we're going to call paid baseline paternity leave that could be taken at the same time while mothers are also on leave, and it has to be used within the first 2 months after childbirth. And beyond these days, parents could only be on leave at the same time, part-time, while also working part-time. Okay, and basically the total amount of leave benefits cannot exceed the equivalent of a full-time job. But since virtually all mothers are on full-time leave in the months following childbirth, this rule effectively restricted fathers' ability to be able to use paid leave in order to stay home at the same time as the mother, right? So because if both parents stayed home, one essentially would have to forego paid benefits on the same time. So just to give you a general sense of how this typically works in the median household in Sweden, so this is based on actual data of parents of first children in 2008 through 2011. So here's the child's birth, right? Then the dad takes his maximum of 10 days of full-time leave, right here in the first couple of weeks. And then essentially the median mom is on full-time leave for the first 14 months of the child's life on her own, okay? Then the median dad does take his, at this time, Sweden had 2 daddy months, and the median dad is in fact taking the full 2 daddy months. But critically, these 2 daddy months are happening after the mom has already taken her leave spell and is returning to work. And then, the child becomes eligible for publicly provided childcare around age 1, but there's wait lists. So in practice, most kids end up going to childcare right after the dad is on leave. Okay, and then, there's some of these leave benefits do remain. And in fact, both parents can continue to use these benefits on a flexible basis up until the child turns 8 and then in more recent years, 12 years old. Okay, so what we're trying to look at in this reform is essentially, as I'll explain in just a couple slides, the reform made it so that fathers were more flexibly able to take some leave right around here while the mother is also on leave. And we're going to look at what happens to maternal postpartum health. Okay, so this double days reform, which happened on January 1st, 2012, allowed both parents to take full-time paid leave benefits at the same time for up to 30 days during the child's first year of life. And this is in addition to those 10 days of baseline leave. There were no other changes to the parental leave system at this time. And so given the pre-reform leave use pattern that I just showed you, this reform effectively increased fathers' flexibility to be able to use paid leave on an intermittent basis during the postpartum period. So to look at the effects of this reform, we're going to merge together multiple Swedish administrative databases. I can't go through a ton of detail here, but basically we have, birth records, which have detailed information on the pregnancy delivery, merged to parental leave claims, merged to inpatient and outpatient records for specialist visits. We do not, unfortunately, have data on primary care visits, as well as prescription drug claims and basic demographic information. Okay, so our research design, again, I'm not going to go into a ton of detail, but the basic intuition is in our preferred model, we're going to compare parents of kids who were born in January through March 2012, right, the first 3 months after the reform went into effect, relative to the parents of kids born in the 3 months immediately before the reform, and to net out seasonal differences across January through March versus October through December births, we're going to compare that difference to the 3 previous years. Okay, and we're going to control for a range of parental background characteristics. So first, like here's sort of like, so to speak, the first stage in terms of the share of fathers who are using their parental leave benefits in the first 60 days and the first 180 days following childbirth. And you see there's sort of an increase, both in immediate leave use and then, in leave use more generally in the first 6 months after childbirth. And this is again on top of those baseline leave days. In terms of magnitudes, what's interesting here is that we see relatively large impacts on the extensive margin. So fathers are more likely to use any days of leave during this time period, but the total number of leave days used is not that large. So most of this leave use, most of the effect of this is being able to take leave on the margin, sort of a day here and there, versus sort of a lengthy period of time. And this already shed lights on what families are using this leave for, right? Remember, the reform did not do anything else to the parental leave system. So in particular, it did not extend the total duration of leave available. So this means that any given family bears the cost of a father being able to use leave in the postpartum period by foregoing the ability to use that leave later on, okay? And so they're only gonna use this leave benefit if the father's presence in the home and in any given day is particularly valuable. And when is that going to be valuable? Well, it's going to be really valuable on days when the mother is having some kind of health issues due to her postpartum recovery, whether it's a physical health issue or a mental health issue. Okay? So with that in mind, we look at the effect on a range of maternal postpartum health outcomes. So first we look at outcomes in the inpatient as well as outpatient data. And we see a large reduction in the likelihood that mothers have either inpatient or outpatient, specialist outpatient visits for childbirth-related complications. So most of these are going to be due to things like infections. And so we see a reduction in this, and it's particularly pronounced among mothers that have a prior medical history or have complicated pregnancies and births. So one sort of example of what could be going on here is, a fairly common infection in the postpartum period is related to breastfeeding, so mastitis. And the common recommendation from physicians on how to deal with early symptoms of mastitis is that a woman needs to rest and breastfeed and sleep and sort of in order to avoid further complications. Now, if a woman is alone with a newborn child and nobody else to help her, it's quite hard to rest and sleep. And so having the father be able to flexibly stay home during that vulnerable postpartum period could actually reduce the likelihood that the early symptoms of mastitis develop into something that's much more serious and leads to more complications, okay? Now, everything that we're measuring here is using healthcare use data. So, we're not able to measure kind of underlying incidence of health issues. We're able to measure healthcare utilization. So you might interpret this in a way like, well, maybe women are foregoing care that they otherwise would have, needed or wanted. So one way to get at this is we look specifically at differences between effects on planned and unplanned visits. And we see that all of this is loading entirely on unplanned specialist outpatient visits. We can also look at the prescription drug data. And the main thing that we find there is we see a reduction in the likelihood that mothers are using anti-anxiety medication in the first 6 and particularly in the first 3 months after childbirth. And we see a large reduction in the likelihood that the mother needs any antibiotic prescription drugs. And again, this is consistent with the reduction in childbirth-related complications and the likelihood of infection. Another sort of interesting question is, kind of what's going on. Like you might imagine that, if a dad is able to take leave flexibly while the mother is having a health issue, on the one hand, she might, stay home and rest, and that might lead her to avoid needing additional medical care. On the other hand, she might seek more prompt medical care and avoid complications further. So even though unfortunately we can't observe primary care visits where some of this might be going on, we can nevertheless use our data to look and see whether fathers take leave on exactly the days on which mothers have specialist outpatient care. And we in fact see that their form enables fathers to be able to take leave on days that overlap with the days when mothers seek medical care, at least for mothers that have a complicated medical history. Okay, so in sum, we find that this double days reform significantly increased the likelihood that fathers are able to take leave and be in the house shortly after childbirth. The effect magnitudes are quite large in relative terms and mostly operating on the extensive margin. And we find that this option for fathers to be able to stay home flexibly improves maternal postpartum health. We see a reduction in the incidence of inpatient and specialist outpatient visits for childbirth-related complications driven by unplanned visits, a reduction in antibiotic drug prescriptions, as well as anti-anxiety drug prescriptions. So we think that our results provide some new insights about the roles of family leave policy in the home environment more generally in influencing maternal postpartum health. The fact that we see this large maternal health benefit stemming from quite a small increase in the average number of leave days taken by fathers suggests that sort of these types of workplace flexibility policies more generally can be actually highly cost effective because they leverage families' private information about when it's the most beneficial to stay home relative to the cost of missed time at work. And while discussions about sort of general lack of workplace flexibility and paid family leave, in particular in the United States, often focus on the direct career costs that this has to the mothers, our findings suggest that mothers also bear an indirect health cost when their partners cannot flexibly take leave. More broadly, this and other research in this vein, I think really emphasizes the importance of public policies for families that in influencing health outcomes in this critical period of life of the transition into new parenthood. So I'll stop here and I'm looking forward to your questions. Thank you.
Fantastic. Thank you so much, Maya. And we have quite a lot of questions here. So we're going to take the full 10 minutes here for questions before we take our break for the next session. Let's start with a question from Claudia, which is kind of a timely question that's related, which is, obviously there's been quite a few changes with working from home with COVID and COVID generated restrictions. Have you or other people kind of thought about using those restrictions to think about these kinds of issues related to leave and flexibility?
Yeah, that's a great question. And I think that's, I mean, this pandemic is really bringing to the forefront a lot of these issues. Another related topic, it relates to the things Katrine was talking about, was that there's been already evidence showing actually a substantial decline in preterm births and NICU admissions due to the COVID, during the COVID pandemic. And people are, we don't know exactly why that's happening, but people are attributing that potentially to reduced stress because especially women in occupations where they're on their feet and sort of working a lot till the end of the pregnancy, we're no longer doing that. Am I working on specifically on research? So as somebody who had a baby 6 months ago, so I'm kind of in the sample of people, I haven't actually had the bandwidth to take on a lot of new COVID research at the moment, but I'm starting to get my feet wet, and that's definitely something that's on my radar, and I hope to be able to look into. I think it's a really important question.
Yeah, talk about living your research. That's certainly giving you some experience one way or the other. Okay, I have another question for both of you, and there's 3 questions that I'm gonna try to basically condense into one question. So I'll give a little bit of detail. So the question is, what do you think about the optimal length for statutory paternity leave in the US? A way to ask it is, what would that be in your opinion and based on the evidence Then there's a related question of kind of what are the relevant differences between Sweden and the US or Norway and the US for thinking about this work. Now, two underlying factors, that I think we have in mind are kind of, you guys have both told us quite a bit about the substantial benefits of leave programs and programs related to caring for mothers and children. But the flip side of that, of course, is like, do you know anything about the estimates of kind of the tax and productivity costs associated with these programs? And then a final aspect of this question is just, taking all that into account, it seems very clear that these are policies that the US should implement, at least to me. I'll speak for myself. Are there any other factors besides just kind of general policy unwillingness that make it harder to do this in the US? So sorry, that's a whole grab bag of stuff, and each of you can kind of take turns as you see fit.
Yeah, so I can take a stab at it, and then I would love to hear what Katrine has to say on the topic as well. Okay, so in terms of optimal leave length, I've been asked this question before, and so I've had some time to sort of settle on an answer. And so if I had to give a number, I would say something like 6 months and not longer than a year, okay? And the reason for that, now, of course, this is not, nobody has been able to perfectly identify the optimal leave length. That paper has not yet been written. I don't think it's possible to write that paper, right? But the general consensus, I would say, from the vast body of research on paid leave policies around the world suggests that sort of the main adverse effects that exist come from really long leaves that are, longer than a year, and, in terms of maternal career trajectories. Now, there's newer work out there now about fathers and the career costs to fathers from taking leave. And that, that work is suggesting that there might be career costs at even shorter lengths. And, I think that a lot of that has to do with sort of stigma and signaling and all kinds of issues associated with men taking leave. And I think, the research showing out of Denmark showing there's sort of peer, or maybe it's Norway, correct me if I'm wrong, the peer effects of paternity leave use suggest that sort of there might be important, as more and more fathers take leave, these types of costs might go down. The other thing I would say is in terms of other types of costs, so of course the main cost that people worry about is the cost facing employers. Now, in the US setting, the existing state level paid leave policies are almost entirely funded by employee payroll taxes. So there's no sort of statutory cost that employers are paying. They're not paying the benefits themselves. But of course, they might experience other costs, such as needing to replace the workers and figure out how to coordinate the work. I've been involved in several different efforts to try to get a sense of these costs through surveying, especially small and, a lot of these concerns about costs are especially relevant for small employers that might not have sort of the resources to figure out how to deal with this. So I've been involved with some work with Jane Waldfogel, Chris Room, and Ann Bartel, surveying various small, medium-sized employers. For example, we went in and surveyed firms in New York, Pennsylvania, and New Jersey before New York's law went into effect, and now we're following up with them to see what happened. Broadly speaking, the preliminary results from all of that suggest that, these employers are not experiencing huge costs. Okay, so that's kind of what we know on that so far. And then finally, and then I'll stop there, in terms of what's preventing the US from implementing this policy, honestly, I think the US has a much bigger sense, much bigger impression that these costs are really big for businesses. And so sort of like the Chamber of Commerce and other kinds of organizations that speak for small business groups are quite, I think, vocal in this discussion. But I think there's been more movement on it. So, depends, I guess, what will happen in the next election. What will happen next?
So I'll just add a few small things. One thing is that I think also around something like 6 months, at least not more than 1 year, and some evidence on that is that if you go much beyond 1 year, you start to see some of the negative effects, especially on women carriers. So there are some papers showing that if they are staying too long, they really drop out. And then also you actually for children, you see that if they don't enter childcare, if they wait too long, that's not necessarily a good thing either, because there are benefits of starting to socialize also in high quality childcare. So you get some of these effects coming in at some point. Yeah. So exactly where it says it, like Maya says, is hard, but something like in that ballpark is the evidence that I've seen. For the US, I think the evidence from Scandinavia and many European countries is that if you make this universal for all fathers and all mothers, the firms cannot avoid, like all firms have to take the cost. So it's not really that much of a distortion anymore in some sense, because like that's a big chunk of the workforce. But other than that, I don't know a lot of it. I think we need more research on that question. It's very interesting.
Yeah, no, that makes total sense. You know, both of your guys' answers are really like illuminating. One question I want to direct towards Katrine, which is from Carol Proper, kind of relates more to the specifics of your work and looks at kind of the impacts of, or kind of when you're assessing the health policies and the education policies. Her question is whether you should compare the interventions at the same age, so that you can kind of say something about which of these policies have a higher payoff. And I'm not sure I fully understand the question, but I think what Carol is asking is, well, you know, at a given age, if we're thinking about implementing one of these policies, is that the right point to kind of assess their comparative values?
So I think it's a great comment. So I didn't really have time to, so I think that last comment from me was based on reading many more papers than just the two I showed you. But I think you have a great point in the sense that if you just took my point that that showed evidence for 0 to 1 year old, you can't really have education policies for that group. And of course, you have education policies in childcare that shows big benefits too. So it's not. So I think that's an interesting take. But I think the reason I was putting that point, which I didn't get across a lot, is that many of these health policies are actually much cheaper than education policies. Like childcare policies are usually very expensive, and even with benefits, it's actually not clear that they pass any cost benefit if you do that. But well, many of these health policies are actually quite cheap. It's like even in school, like having more access to nurses and things like that have also been shown to have benefits for children and so on, which is actually very cheap compared to large resources maybe put into to more teaching or class sizes or all these type of policies. But, yeah, it was I think we need much more papers and discussions before I can be sure on that.
Yeah, and so I'll just wrap up quickly with 30 seconds on one issue, which is that I think both of your guys' papers show very clearly just the great value from these kind of integrated administrative data sets that we've seen so much of in Scandinavian countries and Northern European countries. And, you know, those data sets are used to study many different questions across economics and even, you know, not in economics. But I think, you know, to me, the evidence you guys present, it's so compelling. And it's something that in the US, as you guys both pointed out, is just it's super hard to do, especially at a very comprehensive level across the US overall. And I just think that it kind of speaks to the fact that in addition to goals around the health policy themselves, goals related to kind of data formation and data integration are important goals. So I think the work shows that very, very clearly. Thank you both so much. This is an incredibly fascinating session. Now, in the interest of time, we're going to take a break before we get to our final session. Let's take a 12-minute break and start the final session at 12:10. And the next session is going to be Claudio Lucarelli and Stephen Duckett talking about the healthcare systems in Chile and Australia, respectively.